And so thank you so much, everyone, for joining us for NAMI Maryland's 40th annual conference. My name is Mike Perez, and I am a volunteer with NAMI Maryland. I will be your moderator for this session today. This workshop session is called Childhood Traumatic Stress 101, What You Need to Know, presented by Mr. Casey Anderson from Equilibrium Mental Health LLC. And you can read more about our amazing presenter, including his full bio in the digital conference program on the official conference website. Now, this presentation serves as an overview of core concepts related to childhood traumatic stress, and it is a basic introduction to trauma, various types of trauma, common behavioral and emotional reactions to traumatic exposures, and also evidence-based treatments. Now, if this is not the workshop you meant to attend, now is the time that you can just hit that black button on your browser or click on the sessions button on the left-hand side of your screen to return to the full list of workshops that we have available. We will be addressing questions at the end of the presentation. So if you have any questions as the presentation continues, please place them in the Q&A on the right-hand side of the screen. And I will be reviewing the questions as they come in. And if something particular is unclear or needs to be expanded, I'll ask the presenter after the presentation has concluded that particular question. And we're also excited that we are offering closed captioning for this year's conference, and captioning is available through the desktop or laptop only, however. And to enable captioning, just click the CC button at the bottom of the screen underneath your presenter. And once you click the icon, your video will get smaller and you'll be able to see the captions generated underneath. If you have any questions, comments, concerns, or technical issues, please post them in the chat section of the site, and our technical assistant Sabrina will address them accordingly with you. And now I'd like to welcome our presenter for today's workshop, Casey Anderson. Thank you so much for joining us today.
Thank you, Mike. That was very wonderful introduction. And most importantly, thank you to NAMI Maryland for having me here today to discuss a topic that is near and dear to my heart. Like Mike said, my name is Casey Anderson. My pronouns are he, him, and I'm thrilled to be able to talk about a really important topic today. Now, just for folks' background information, a little bit about me. I'm a licensed clinical professional counselor, which is an LCPC, kind of like therapist slang for a psychotherapist. And by trade, I have typically worked throughout the span of my career exclusively with children, adolescents, and their families, the majority of whom have been impacted by trauma in some shape or form. I'm also a registered play therapist, and I also use predominantly two evidence-based treatments to really help folks who have experienced trauma reduce different symptoms and problem behaviors. Those two main types of therapies that I employ include trauma-focused cognitive behavioral therapy, TFCBT, as well as another type of therapy called dialectical behavior therapy, or DBT. And yes, I said dialectical. No, I did not say diabolical, as many folks often hear. I'm going to go into some evidence-based treatments today, a little bit more in depth. But before we really get started with our presentation, I kind of want to give just a basic kind of heads up about what you're in store for. So if you have never, ever really learned before about traumatic stress or post-traumatic stress disorder, if this is your first time, the first thing that I really want to say is that you have absolute permission as you are absorbing this content today to take it easy. A lot of this information is highly emotionally charged, and it can be very provocative. It can be rattling and jarring at times because what I'm going to be discussing are some of the worst atrocities that could really befall any human being. And in particular, I'm talking about children, the most innocent of humans. So it would make sense, and it would be quite natural that if we were learning about a particular type of trauma, you started to feel distress, you noticed it rising within you, to go and take a break, go take 1 or 2 minutes, get a drink of water, take out your phone, play a game, call a friend, whatever it is that has to get you back down to sort of an emotional baseline, do it. You have my permission to go do it. That is the best way to kind of optimize learning and come back in the service of self-care. The other thing I want to let folks know is that as it relates to childhood traumatic stress, one of the images that's often kind of talked about is this idea of an iceberg. And this iceberg, like many other icebergs, we can see what is above the surface, what is known. And I'm going to be, talking a lot about today about some beginning introductory information. And what I also want to give people a heads up about is that below the surface, there is a wealth of information that I'm not going to be presenting on today, and key information that even as social scientists is unknown. So on one hand, I think you're going to learn a lot today. And on the other, there's going to be a lot of questions still lingering. Like I said, I'm a counselor. Chief among some questions that might be lingering, I'm not going to be really going over a tremendous amount of information today about brain-based science and how traumatic events can impact neuroscience or neurobiology. I believe the last slide of my presentation is all about, not all about, but it's my contact information. My email address is on there. And I want to encourage folks that if for whatever reason I can't get to your question or concern today, please shoot me an email. If I don't know the answer to your question, I will be happy to direct you to the folks that do. I want to say that I'm really indebted to the Kennedy Krieger Institute, a very well-known hospital in the greater Baltimore area, for allowing me to really stand on the shoulders of giants and learn quite a deal about childhood traumatic stress. So with that said, I'm going to go ahead and share my screen now without further ado. Okay, and like I said, I know that I can get to yabbering, and if there are questions or you have concerns or you just, have something that you want to get off your chest, please put it in the chat. I'm going to do my best to kind of stay on our timeline, so we've got enough time at the end for there to be a question and answer period. And I love taking questions because learning is a two-way street. I often find that as a presenter, I give a lot of information, and at the same time, I can also learn a lot from other people's walks of life too. All right, so in terms of presenter disclosures, I don't really have any presenters disclosures or, any kind of mutual affiliations, except for the fact that I guess I should mention, I do co-own a private mental health practice here in Maryland. It's called Equilibrium Mental Health, where we really have a clinical focus on helping kids and their families with what's called pervasive emotion dysregulation, which also happens to include treating traumatic exposures. The name of our practice is Equilibrium Mental Health, like Mike had mentioned. And from time to time, you might see like a lowercase e on the slides. That's our logo. That's just, our practice. All right, so 3 main points that I want to make sure I sufficiently cover for today. First and foremost, I want to be able to talk about common behavioral and emotional presentations of childhood traumatic stress and also what teens might go through as a result of trauma. There's going to be a real kind of developmental lens towards sort of the mid part of the presentation when we're looking about how developmentally across the lifespan, PTSD or trauma responses can be different depending on your age and sort of what's going on within that developmental window. Secondly, I want to be able to kind of give a brief introduction into what is evidence-based trauma treatment and what that means. And, if you are a parent or a healthcare provider and you see that on a website or a brochure, that when you spot it, you know exactly what it means and its usefulness. Third, although we are, let's say, in some ways, there have been many improvements as it's related to COVID-19 within the past year or so, I want to emphasize that we are not completely out of the woods yet. And I do want to talk about the role of COVID-19 as a significant environmental stressor and how that impacts children's functioning. All right. So first and foremost, let's start here. What actually is this thing called trauma? So trauma refers to those intense emotional experiences or events that can be life-threatening in nature, that can actually be perceived or in real life actually happening, and it could threaten a person's sense of safety. And by sense of safety, I mean psychological functioning or bodily safety, like their bodily integrity. And these threats or this sense of harm usually overwhelms a child's basic ability to be able to cope in the moment. So it's very much so different from your run-of-the-mill everyday stressors in that because these stressors are life-threatening, children and adults alike, their basic capacities to be able to cope are insufficient. They just aren't going to be able to manage the onslaught of distress that usually accompanies a traumatic event. And then the other kind of key information to be mindful of as it relates to trauma is that the aftermath of the event itself usually has some kind of impact on a person's functioning in various settings or domains. So for kids, you might see different kinds of problem behaviors at home, with family members, with peers, with their own health. You might see problems at school, in the classroom, whether that be on the sports team. If it's a kid who's in drama or plays, you might see problems there. You notice how traumatic events continue to kind of adversely impact functioning well after the event has passed. Now, another question might be, well, what exactly is a traumatic event? And really, I think one of the glowing hallmarks about trauma is how this kind of intense event can elicit a highly charged emotional response. In other words, there's elevated fearfulness, horror, terror, just this overwhelming sense of being incapacitated and helpless or hopeless in the moment itself. And sometimes the event can be completely dangerous, violent, or very scary. And like I've mentioned, it might be a threat to the person's bodily integrity. Now, I should also mention this. A child doesn't necessarily have to be the direct target of a traumatic event itself. They could be an observer or a witness to a traumatic event and still go on to develop trauma-like or PTSD-like responses, even though that they were not necessarily that direct target. For example, a child who might be in the classroom and, there could be something like a school shooter, unfortunately very real, especially in our current society. If something terrible, God forbid, happened like that, and a school shooter were to go into a classroom and witnessed a teacher be harmed, even though that child might not be the direct target of that violence, they watched a significant attachment figure watch kind of like unsafe things truly happen to them. And for children, one of the things that really can kind of serve as a safety cue is what's going on with adults or trusted attachment figures in their environment. Children take their cues about how to behave and their safety, if they're okay, from the trusted adults within their environment. So quite naturally, if a teacher were to be harmed, the next thing that's kind of triggered for a child is, oh my gosh, what kind of peril or danger is happening to me right now? So the bottom line is this: when it comes to traumatic events, kids don't necessarily have to be the direct target. They can be witnesses or observers to the events themselves. Now, there's a whole host of different traumatic experiences that can happen from time to time, unfortunately. And I really want to give folks a heads up to this list and start off by saying that this is not an exhaustive list of different trauma types as you're looking at these different bullet points. For example, One type of trauma that's not on this list that I commonly treat and help out with is bullying, or in the scientific literature, what's referred to sometimes as peer relational aggression. The reality is that given the variance in human experience, there is a multitude of different traumatic exposures. And at the same time, the good news is that there are many resources out there that might be able to speak to a type of trauma that you want to learn about that's not on this list. There is a wonderful resource that is within the public domain for kids and families. The abbreviation is the NCTSN, and I've got to do some mental gymnastics real quick, but that stands for the National Child Traumatic Stress Network, the NCTSN. And there's a host of different webinars, didactics, and educational materials for families where you can learn about trauma and the best ways to be able to help children and families. If for whatever reason there's a trauma type that's not on this list, please do a quick Google search, look at the NCTSN. I guarantee it will be one of the most helpful resources you will discover. So without further ado, I do want to go into some common trauma experiences that sometimes kids go through. First bullet point, physical, sexual, or psychological abuse and neglect. So physical abuse can vary in its definition from state to state or provider to provider, but more or less what that references is an interaction between usually an adult and a child, wherein an adult might use physical force or violence to be able to inflict harm on a child. And that harm might be seen in the form of physical injuries, broken bones, scratches, burns, you name it. And this kind of harm can occur either intentionally or unintentionally and still meet the criteria for physical abuse. Similarly, sexual abuse entails this idea of an interaction between usually an adult and a child, wherein the child is the object of sexual stimulation to a perpetrator or another observer in the environment. Now, I also want to note that, perpetrators of sexual abuse don't necessarily have to be adults. They can also be other peers and children. And oftentimes when there's this kind of sexual abuse happening between children to children or minor to minor, we think of it in different ways, oftentimes, in the sense that, when there are kids who are exhibiting sexual or problematic sexual behaviors towards peers, it sometimes is motivated by their own sexual abuse histories. And because of that reason, we use some more compassionate language to be able to discuss those problems as well. The other kind of things I should mention on this first bullet point are in relationship to psychological abuse and neglect. And this is the idea essentially or broadly, and again, this definition varies too, but the idea that a child's needs are not being sufficiently met, whether that be emotional or social needs or medical, developmental needs. And as a result of not getting these needs met by a caregiver, there is significant kinds of problem behavior, symptoms, developmental delays, and it's a direct kind of relationship between a lack of getting needs met and these presenting problems and symptoms. The second bullet point on here, natural and technological disasters or terrorism. I think that one's pretty straightforward, but even as we think, most recently about Hurricane Ian, and we think about, lives really being negatively impacted by the destruction of natural disasters and how that can elicit elevated senses of fear and even PTSD, like common reactions like nightmares, hypervigilance. All sorts of those kinds of behavioral displays can happen after a natural disaster too. Another traumatic experience could be different family or community-based acts of violence, whether that be like gun violence in the community or physical assaults, gang violence in the community, or even on the home front, what once upon a time was really referenced as domestic violence, or is now, kind of referenced in the literature as interpersonal or intimate partner violence, That is another form where caregivers in the home might be violent to each other and a child's sense of safety is threatened. There could also be a sudden or violent loss of a loved one, and that could be due to something like homicide. And obviously, that can take an emotional toll on a child or a teen. Similarly, adults, especially at home, who might have severe substance use disorders and who are using all the time, and as a result, they might have, their own host of different kinds of problems that can negatively impact the way that a child develops or functions. Refugee and war experiences, including torture. I think that one's pretty straightforward in terms of how it might adversely impact a child's level of safety or functioning. And serious accidents or life-threatening illness. So a serious accident being like something like a car accident, or a serious illness like they themselves developing something like pediatric cancer and feeling incredibly scared about whether or not they will survive themselves. Military or family-related stressors. This could be like deployment or losing a parent due to some kind of terrible act of war. And the other type of trauma I actually included on this is called information deprivation trauma. And this is one that, usually I think a lot of people don't know about or have a lot of information about. And it's this idea that communication barriers themselves sometimes, when a person has insufficient means or ways of being able to access key information, that can be emotionally activating and really upsetting too. So let me give you an example of this to kind of illustrate my point. Once upon a time, I was very active in treating children and families who were deaf and hard of hearing. And for one family in particular, I was helping a mother whose trauma history was significant for information deprivation trauma. In her particular history, what had happened, she was in her apartment complex with her two children. I think at the time they were like roughly 7 and maybe 6, kind of stair steps, if you will. And mom had gone to the laundry room in the apartment complex, and the kids were in the apartment. And mom had left her cell phone in there because she was just making a quick trip to change the laundry. And lo and behold, unfortunately, while she was in the laundry room, alarms started going off and they had to evacuate the building because there was a fire. And mom, I should mention, is deaf. And she predominantly used American Sign Language to be able to communicate. So mom was blocked from being able to get back to her apartment because of the masses of folks who were saying, evacuate the building, you have to go out, no, you can't go up to the room. And so she was forced out and separated from her children who were hearing. And so she goes outside, and as you can imagine, she was in a complete frenzy, horror-stricken. And she was trying her best to be able to communicate with folks, but the majority of whom were hearing individuals who they couldn't sign, they didn't know ASL. And so for about a half hour, she was scrambling to find her children while there was this burning debris of the building. And you can only imagine what kind of thoughts were going through her mind about what happened to her kids. And her phone, by the way, like I said, was not on her. So it wasn't like she could use some kind of interpretation service to speak to hearing individuals. She had no access to communication. So her mind itself sort of invented justifiably the worst possible outcomes that could be happening to her children. This comes with a happy ending. Her children were safe and sound and they were discovered. And there was an interpreter who eventually was able to come on the scene with different emergency responders. But this is what I mean by information deprivation trauma. Not having sufficient communication methodologies to be able to really inoculate oneself or cope with stress, especially traumatic stress. And as a result, this mom unfortunately had PTSD-like reactions despite the fact that her kids were safe and sound. So moving on to COVID-19, I think, this one's pretty straightforward too in terms of how this has negatively impacted adults and their families and children. But more or less, COVID-19 turned the world upside down. And for children in particular, whether they themselves might have been infected by COVID-19 or they had a close family member be infected by COVID-19, with all the information that was out there on the news, discussions with peers and friends, the reality is that many people died from COVID-19, and it would make sense that there would be an elevated fear of death or that their safety would be impacted if they themselves got sick or they had a family member who was hospitalized. In which case, if they had a family member who was hospitalized, they might have separation anxiety, a lot of worries or concerns about how their caregivers are doing and whether or not they would survive. And for like pre-adolescents, like middle schoolers and teenagers, unfortunately, what a lot of the data showed us was that this population of kids started to rely more on harmful ways of coping, including like drugs and alcohol. And I think that it goes without saying that COVID-19 really kind of, like I said, turned the world upside down, and daily routines and schedules were totally disrupted, which in many ways are antithetical or unhelpful for children's functioning, given that developmentally, even for adults, we thrive over predictability. What is known, what we know is going to happen in the morning, in the afternoon, into the evening, how we're going to be able to communicate with other people, what to do when. And there was really an absence of that kind of structure as a result of COVID-19. So there was tons of emotional disarray. Now, I would be totally remiss if I did not underscore or shed light on the very active role the mental health community has in elucidating new research and data as it relates to racial trauma. So racial trauma refers to people of color and Indigenous individuals' reactions to dangerous events and real or perceived experiences of racial discrimination. All right, so in a nutshell, what that really speaks to is race-based stress that has been perpetuated over time on the basis of discrimination, prejudice against one's race, including implicit bias, and how, as a result of these inequalities, it's really disadvantaged folks, especially folks obviously of color, over the years. And these kinds of traumatic events are embedded in American history, obviously dating back all the way to slavery. For folks of color, having mistrust for those who are perceived to be, or are rather, in power, white folks. And as a result of obviously justified levels of anxiety, people of color experience discrimination sometimes on a level that meets criteria for post-traumatic stress. Now, how does this interplay, especially with children of color? Well, one of the things that's happened, especially within the past 5 to 10 years, is that there's been increased exposure to how folks of color have been mistreated by systems that are thought to be trusted within our society. And for especially kids, because of access to things like the media or the news or YouTube, they're seeing a lot more of these race-based stressors, and they're saying to themselves, wow, you know what? I cannot believe this is happening. This person looks just like me. They share the same racial makeup as me. I am actually very frightened and afraid that these kinds of things could happen to me. And as a result, they can obviously be traumatized or experience what this bullet point on there, the third one, is referencing as vicarious trauma, or what's sometimes called secondary traumatic stress. Again, this idea of, hey, maybe this event didn't directly happen to me, but because I learned about it, I'm aware about it, and it's really hitting close to home, I myself might be traumatized too. And so as a result, a child can experience similar reactions to PTSD including the full gamut of responses and reactions. Hypervigilance, which is this idea of kind of our brain's alert system being very activated, kind of scanning for danger, even during times where we might not expect it to be there. Flashbacks, this idea of intrusive thoughts of events just kind of popping into one's mind in In this case, it might be intrusive thoughts or images that relate to what's on the media, and kind of having a justifiable sense of alarm and terror. And also experiencing kind of a sense of avoidance and trying to push this out of our minds, and accompanying somatic complaints. Somatic complaints being like, because I'm so overwhelmed with stress, I might be experiencing especially stomach aches or headaches, or I might experience hypertension, just a lot of kind of undue aches and pains as a result of having this exposure. I also want to kind of cover real quick this idea of simple versus complex trauma. And these are two categorical ways of looking at trauma itself. Now, to me, there is nothing simple about trauma. I think that in some ways that's a reductionistic term, but it is a way more or less, like I said, of organizing information about simple trauma, which AKA, it's also known as single incident trauma. And that's exactly as it sounds. It is when an individual might go through one singular exposure to trauma, for example, a car accident. There's typically a beginning and an end to it, or a highly invasive medical procedure that might involve like a lot of like prodding and very hefty recovery time or hospitalization. Oftentimes that falls within the category of single incident or simple trauma. Now, in contrast to simple trauma, there is what's known as complex trauma or developmental trauma, as the case may be. And so I'll tell you that I can count maybe on one hand how many children I've treated who meet the criteria for single incident trauma. And the vast majority of children that I've, really helped out over the years have a complex trauma history. And so complex trauma refers to the sum total of multiple traumatic exposures. A child, typically actually going back to very early years of life, who might be exposed to things like neglect or, intimate partner violence or physical abuse or sexual abuse or different types of traumatic exposures over the year. And essentially what happens is there's kind of a compounding effect where it's one trauma after the other, and it really impacts a child's sense of safety and their ability to form attachments with trusted folks that actually can sometimes extend well into adulthood. And this can impact folks in the sense that they can experience sort of what's like waxing and waning trauma reactions, where there might be periods of time in their life where, trauma symptoms aren't as present, and then they might really flare up again as a result of these cumulative experiences. So more or less there, and this is really kind of broadly describing it, but simple trauma is more based on single incident exposure versus complex being cumulative experience of traumatic exposures. All right, some statistics just about the prevalence of childhood trauma. 2/3 of kids report that at least one traumatic event happens to them by age 16. And as you see how, the criteria for a traumatic event or different trauma types is so broad, this statistics makes a lot of good sense. 8 to 12% of kids of American youth have experienced at least one incident of sexual assault. About 9 to 19% of kids have experienced physical abuse by a caregiver or physical assault in some shape or form. And I know that this next bullet point is kind of a big range, but 38 to 70% of children have witnessed serious community violence, meaning like violence that is happening smack down in the middle of different neighborhoods. 1 in 10 children have witnessed serious violence between caregivers themselves. 1 in 5 have lost a family member or a friend due to homicide. And I want to say kind of a piece about this. So one of the trauma types that I did not go over in the slides prior was this idea of what's called traumatic grief. And you might hear that from time to time, but traumatic grief usually happens when the death of an attachment figure like a parent or a caregiver occurs, and it is of a particularly violent or gruesome nature. And a child, like I said, doesn't necessarily have to have direct observation of a homicide or a violent murder or some kind of death. They could be just learning about it through conversations that they hear with other caregivers or their siblings, and as a result can develop a form of grief that isn't like typical grieving, but instead it's not just coping with loss, but developing post-traumatic like stress responses. So in addition to like typically functioning sadness, if there is such a thing that's out there, there are more like cardinal symptoms like flashbacks, nightmares, things that resemble PTSD. And, you know, kind of going back to the last bullet point here, about roughly 9% of kids also will say that they have experienced, you know, kind of internet assisted victimization, or, you know, it might be referred to sometimes in older literature as like cyberbullying or online bullying in some shape or form. All right, so the next set of slides is really going to focus quite a bit on signs of trauma. Or different things to kind of look out for. And like I mentioned earlier, I'm going to go kind of in developmental pockets or spans of time, because the reality is that children manifest trauma symptoms and signs differently depending on their age or what they're going through, or sort of what developmental milestones are being met at the time. So I want to make sure that I'm emphasizing the fact that these are just kind of key takeaways for each developmental bracket. And there are also signs and symptoms within each age bracket that are not going to be captured on these slides per se. So starting out as young as infants to toddlers, 0 to 3, believe it or not, within this age bracket, you will see withdrawn behaviors. You're going to see reduced affect, or what we might refer to as blunted affect. And what that refers to is kind of, even with kids this young, a flattening of facial expressions or emotional presentations. And you might even see that as a result of their safety being threatened, a lack of curiosity about their environment. In other words, they don't feel like crawling around or exploring because they are oftentimes so frozen in fear to do so. Lots of times it might look like they're unattached, as if the lights are on but nobody's home. And they might even present or swing in the opposite direction, being overly clingy with caregivers, being more anxious, having even more sleep disturbances than what's developmentally appropriate for infants and toddlers. And the other thing to keep in mind is that there can be what's called a regression in skill behaviors. And this is something, especially with younger children, for infants and toddlers, for school-age kids. This is the idea of where, like, there might be mastery of some kind of skill that you might have taught your child. For example, the ABCs, right? And then, you know, your kid might have had the ABCs down pat, and then, God forbid, they went through physical abuse or observed some kind of community violence. And then this constellation of symptoms starts kicking in, and you notice it. And then you notice, hey, let's sing the ABCs together. And they forget it. And you're going, wait a minute, hang on. They had it down pat. How come now they can't recall this information? This is very obscure and strange. This is what's meant by a regression in kind of learned skills or behavior. And obviously, this can play out into a sense of disorganization too. The other thing that I definitely want to kind of shed light on here with this window of development is this idea that because kids in this age bracket don't necessarily have the linguistic development to be able to vocalize what they've been through, just typically developing, kids this young often engage in what's called externalizing problem behaviors. Let me decode that one for you. What this means are significant or relevant temper outbursts, tantrums, physical aggression, emotional aggression, sometimes property destruction that is well beyond what is considered the terrible twos. And it makes sense because linguistically, they don't have the skills to say, hey, I went through this experience, so I'm going to show you through behavioral presentations. Similarly, even if they did have the verbal skills, one of the key hallmarks of PTSD is avoidance. even for adults who can speak their mind and talk about their traumatic experiences, they're going to want to avoid it. And so infants and toddlers are more likely to show their kinds of signs and symptoms through a behavioral presentation of chronic, severe, persistent sorts of problem behaviors. More signs of trauma, especially in preschool, and you're going to see a lot of overlap in these developmental windows. But this is around the age group where kids who have been impacted by trauma will start to show a lot of signs and symptoms related to separation anxiety disorder, which could be looking like sort of like, are you going to be okay, mom, dad, uncle, whomever is my caregiver? I don't want to leave your side. I want you to always be with me. There might be increased school avoidance or like daycare avoidance as a result, and they just have a refusal to be able to separate. And this might look like additional crying and screaming, as the case may be. You might also start to see some things being kind of haywire with what clinicians might refer to as vegetative functions. Vegetative functions, more clinical jargon that speaks to mood, appetite, energy, and sleep, right? So you might see more problems related to appetite, under eating versus overeating, sleep problems, refusal, or actual difficulties rather, initiating sleep, being able to fall asleep, maintain sleep schedules. They might have nightmares. A word about nightmares real quick, by the way, in general about childhood traumatic stress. Nightmares with kids, and really also adults too, but I really want to make this very clear for children. Nightmares with kids the content itself, like what a child might actually see or picture in their mind, might be directly related to a traumatic exposure. So for example, if a child was sexually abused, they might have images that are horrific that pop into their mind while they're sleeping at night, directly related to that content. And at the same time, they may not. They might be complaining just of having increased dreams about scary monsters or being separated from mom and dad. And the themes or the images themselves don't have to neatly map out to the content of the trauma history itself. It can just be scary or bad dreams that sort of meets the criteria for a nightmare for children who go through trauma. More signs and symptoms of traumatic stress. Kids being overly anxious or fearful, they're experiencing more incidents of guilt and shame. They might have problems concentrating. These can be kids who are like all over the classroom, difficult to sit down or be organized. Sometimes if a diagnostician is not very crystal clear in their assessment, they might misdiagnose them with something like ADHD, attention deficit disorder. But the reality is they might have gone through trauma and they have difficulties maintaining their attention and focus. For other pre-adolescents like middle schoolers or even high schoolers, this is where we start to see more profound mood-related disturbances, whether that be depression or more withdrawn behaviors. Chief among them, irritability or like increased snappiness as well. You might also see sort of more like self-harming behaviors, whether that take the format of cutting or engaging in substance use. And you might start to see problematic sexual behaviors or what's sometimes referenced to as out-of-control sexual behaviors too. And these, unfortunately, are like a harmful way of being able to cope psychologically with traumatic stress. So now I kind of built the bridge about, hey, here's the problem. This is kind of what people go through. This is what children go through. What do we do about it? Well, the good news is that there are a lot of what we call evidence-based trauma treatments out there that help children, teens, and their families reduce PTSD reactions. In a nutshell, what evidence-based treatment refers to is treatment that has been designed, researched, and heavily evaluated through experiments where social scientists can, with confidence, say, hey, if you do this type of therapy, you're likely to get this positive outcome or result. In other words, an improved quality of life. Over and over and over again, we see this through controlled trials And we can say with confidence that evidence-based treatments can be helpful. Now, there's another side of the coin of that. I just want to let children and families know is that, healing in and of itself is influenced by many factors, including religion, spirituality, and other factors that are really idiosyncratic or based on the person itself. Evidence-based treatments are not always a one-size-fits-all, and they might not be for everyone. And the good news is there are many different types of therapies out there that can be useful, even if they're not necessarily backed with a breadth of scientific support yet. I'm going to go over some of them today, including TFCBT, child-parent psychotherapy, parent-child interaction therapy, as well as dialectical behavior therapy. So, TFCBT is the gold standard for childhood traumatic stress. And in a nutshell, what it does is it is a child-focused family therapy where parents have active participation in treatment, and it teaches children about trauma, increases their coping skills, and also helps kids be able to narrate or safely unpack their traumatic memories in ways where they can cope with it and retell their story with a trusted figure present. In addition, a therapist might be able to gradually help them use what's called exposure to confront reminders of trauma that they might have avoided previously. And avoidance, unfortunately, is kind of the poison that keeps PTSD alive and strengthened. So the more that we use confrontation to approach those scary things that remind us of trauma, for example, I can't smell alcohol because it reminds me of my perpetrator. The more that we can help folks gradually be re-exposed to that smell, the more they can cope and accept it, and actually trauma symptoms decrease. And there's a lot of great research out there that speaks to the effectiveness of TFCBT. Now, child-parent psychotherapy, or CPP, was originally designed for parents who had experienced domestic violence or intimate partner violence, and their children were also impacted by this exposure as well. It's a really lovely, about a year-long treatment where concurrently parents are able to process their own reactions to their trauma exposures while also finding safe ways of helping their children cope along the way. Parent-child interaction therapy is usually for a younger group of children who present with, like I said, externalizing problem behaviors, which might look like tantrums, oppositional problems. It's roughly 14 to 25 sessions in duration, once per week. And what it really helps parents do is develop new ways of being able to interact positively with their children through behavioral skills, which kind of speaks to building attachment as well. Now, dialectical behavior therapy, this is my baby. This is, the type of treatment that I oftentimes lean on to be able to help out kids and teens who engage in suicidal behaviors or self-harm behaviors, and who also happen to have trauma histories too. And this is a very comprehensive treatment where kids receive individual therapy to build skills and to process current stressors, and families alike will engage in skills training to be able to build their own skills. There's also a really nifty element of this treatment called phone coaching, where teens have access to being able to call their therapist at any time to be able to get helpful feedback about how to be able to cope during stressors or symptoms as they arise. And the last element of DBT is that there's always a consultation team of therapists. So even though you might be meeting with one therapist, you are also meeting with like 5 to 6 at once, giving you the best treatment recommendations. COVID-19 and sort of, kind of thinking about how that's impacted the way that our mental health industry operates. We are able to deliver very effective treatments, yes, in person, but also through telehealth right now. But the note that I really want to make about this is this idea that if a child had some trauma exposures prior to COVID-19 and then they were infected or had a family member who was infected, it could indeed worsen these kinds of problems. But the good news is telehealth can be equally as effective as long as you have a kid who can engage in telehealth practices to reduce PTSD-like reactions. Now, what can you do as a parent or a caregiver to be able to help out? First and foremost, you want to be able to reinstall a sense of safety with kids. And so what that means, I think, for parents is really, first and foremost, prioritizing their own mental health. Because even though you yourself might not have gone through trauma and you know that your child did, that can have secondary traumatic stress reactions on you as a parent. So in order to make your kid feel safe, you have to first and foremost prioritize your own mental health and self-care, which I know is not an easy feat to do. A part of being able to prioritize your own self-care is staying calm and trying to find a way of maintaining daily routines. You also want to try to help kids re-engage in activities that they previously found recreational, things that bring them joy. And if you can, you want to be able to plan these activities, schedule them in such a way that you're serious about engaging with your kids, whether it's something like playing the latest game of Mario, and you say at 2 o'clock, I'm going to play Mario with my kid, and you treat it with the same seriousness that you do of attending a doctor's appointment. You don't miss spending time with your kid, and there are no distractions, no work emails, nothing like that. You also share to some extent, depending on the child's age and developmentally where they are, key information about the trauma, and you try to be transparent. If you don't know what to share, seek out help from a healthcare provider or a licensed mental health professional. You also want to make sure your timing is right, that you're not distracted, your child's not distracted. And as much as you can, you want to try to get some kind of limitations over what your child is exposed to in the media, and understand that your kids might have different ways of coping. And what you want to do is listen very well and help your child develop adaptive coping skills to replace harmful ones. You also want to acknowledge that maybe what they went through is very real, and you can do that by way of validation. Real quick note about validation. It is an essential psychological nutrient that really helps both parents and children alike be inoculated against stress. And it is not the same thing as praise or reinforcement. Folks oftentimes mix that up. A validating response might sound like this. Hey, it really makes sense that you would be feeling incredibly frightened right now before you go to bed, given what you've been through in the past. It is the communication of understanding and acceptance without trying to change the child's feeling and highlighting empathically what a child is going through. And you also want to know that it's okay to not have an answer. You're not going to have all the answers. Even licensed mental health professionals don't have all the answers. So don't get too attached to outcome itself. Now, I know I just went through a lot of information, and one of the things I want to do now is see if there are any kinds of questions or concerns that I might be able to field for folks. So I stopped sharing my screen, and I would love to be able to hear from folks. Any comments, concerns? I'm all ears.
Thank you, Casey. I appreciate that.
No problem.
And that was a very, very rich. I took notes for this one. This was very, very rich. So thank you for so much great information. You are a great presenter. We would like to open up the workshop now for your questions. So please place them in the Q&A on the right side of your screen. And if you don't have time if we don't have time to answer your questions, please send them to connection@namimd.org with the name of this session. Or you can also submit them at the end of the event later this afternoon through the evaluation. And I have one question already in the chat in regards to the role of pornography on children and any type of traumatic stress that may give them.
Yeah, so I think it's Maria who asked that question. Maria, thank you so much for bringing this up. I want to say that this is a difficult question to answer because there are so many variables to consider. So, for example, what I want to say is that depending on where a child is chronologically, right? So if we're talking like a teenager, even to some extent, maybe even middle schoolers, there is a healthy dose of typically developing functioning sexual development where if, a child was interested in pornography, that's natural curiosity is kind of built into being a human. So if they themselves of their own volition are seeking out pornography and interested in it, that might fall within like typically developing expectations. However, I would say if the circumstances are different, if it was like much younger children and they were exposed to pornography, I would say even by accident sometimes, it could be incredibly frightening and emotionally distressing. And yes, I mean, I could say that I have seen kids who have been exposed prematurely to pornography, or in some unfortunate circumstances, even being forced into viewing it, which is a form of coercion. And in my book, it can kind of border on the realm of sexual abuse, wherein, you know, freedom or will is taken away and they're seeing content that maybe they are not developmentally where they need to be to safely view and process this information. What I would say is if there's a kid that has had this kind of exposure, it would be important as a caregiver to have transparent communication around safety and boundaries, and you as a parent doing everything you can to be able to prevent relapse or re-exposure to pornography in general, and having discussions around safety and education about it.
Thank you, Casey.
No problem.
Caroline brought up a question that has to do with comorbidity that goes into adulthood. So let's say you have a mental illness such as schizoaffective bipolar disorder, and you also have multiple traumas that happen as a child. And I guess that were untreated into adulthood. How does that play itself out?
Thank you so much. Yep. I see it in the chat. I appreciate it. I just want to kind of read it for me and let it soak in real quick. I think if I'm reading this correctly, it's the idea of how do you deal with multiple childhood traumatic exposures that perhaps were in some way unaddressed in childhood, and as a result, like maybe later on in adulthood, there were schizoaffective disorder or bipolar type or mood-related disturbances. And in a nutshell, what I would say is that it really depends on the mental health provider who you're talking to. What I would say is that if there was a constellation of symptoms that were potentially life-threatening in nature, like suicidal behaviors or severe self-harm behaviors or alcohol abuse, substance abuse, you would want to, from my perspective, first make sure there's stabilization on that front. And then the second stage of treatment might be more geared towards kind of diving into the various traumatic exposures dating back to childhood. In DBT and dialectical behavior therapy for adults, usually that is what happens. And so you might ask yourself, well, how is that done? And one of the things that in evidence-based treatment we try to do is first tackle what's called the index trauma, or maybe the trauma that is the most disturbing or distressing, the one that elicits the most problems and symptoms for that person. And then as you process it, believe it or not, there's something that happens where folks learn how to process other traumatic exposures because they first have knocked out, or at least found some sense of peace with the one that is driving the symptoms throughout adulthood.
I love it. Thank you so much, Casey. She followed up with a question about resources for bullying.
Yeah. Okay. So as I mentioned, the best resource that I can possibly recommend is going to be the NCTSN, that National Child Traumatic Stress Network. 100% there are going to be resources for bullying. Similarly, I would definitely go to, your child's school, speak to the school counselor. They will also have resources for bullying. And the other thing that I'm always astounded that, it's not more kind of in our daily work is this awareness of what's called a bullying report for schools. And this is a formal way of being able to document any kind of bullying incidents at schools. And then schools actually have an obligation in some ways, once it's on paper, to say, hey, you know what? We're aware of this and we want to do everything in our power too as the school to promote a safe environment, which might mean mediating in some shape or form bullying incidents to prevent any such exposures from happening again. Excellent question.
Absolutely. Well, we have, I don't see any more questions and we have about a minute. I'd like to go back to racial trauma, if I could.
Sure.
What is the recovery rates per se, or how well do children recover from racialized, bullying and whatnot in that period of time?
Mike, that is such a good question. And you know what I will say is that because now there is such an emphasis on us gathering more information about race-based traumatic exposures, the data is still somewhat ambiguous in nature in terms of an exact timeline. What I would say from my perspective is this: given that racial trauma is so embedded in our history, it would make sense that, unfortunately, different harmful reactions and responses, fearfulness, justifiable paranoia about how others might be mistreating them, can last well into adulthood and be problematic. However, it doesn't mean per se that it would be a problem that would persist throughout the child's life. They can develop ways of coping, being able to rely on community supports, and being able to really kind of self-validate and say to themselves, hey, my experiences with racial trauma makes sense. And this is not made up in my head. So unfortunately, I don't have an exact timeline. And the reality is, I think that it can persist well into adulthood.
And this is probably one of more chronic traumas as opposed to others that are in a season, right?
Yes, pervasive, oftentimes pervasive across one's lifespan.
Okay. Thank you so much for answering that question and all the other questions.
No problem.
So at this time, I'd like to say thank you to everybody who came by, who asked questions, who listened, who wanted to be informed. At the end of the conference today, you will receive a link for an evaluation of this workshop. And if you would like to acquire any CEUs for this workshop, please submit your responses